Henry. I'm a headache specialist here in Salt Lake City, and tonight's topic is going to be medication overuse headache, which is a very big problem in this country. Some people think of it more as the old term used to be rebound headache. And medication overuse headache is really a secondary type of headache. Most of the people, when you get down and you break through what is going on, they started with episodic migraine without aura as the most common originating disease, and then rapidly progress or slowly progress over months to years to medication overuse. And as the term implies, indeed, it comes from the fact that those of us with migraine brains, which is a hypersensitive brain, if we take medication, analgesics in particular, too frequently, that it actually ramps up our headache, and as the medications are metabolized and wear off, the individual actually it triggers another headache. And so people oftentimes, you'll find if they go through their history carefully, that they've started maybe with a headache a week or 2 headaches a week, and pretty soon they're having 3 headaches a week. And these individuals with medication overuse, and if you look at large headache institutions around the country and around the world, the incidence of their referrals that have some element of medication overuse headache can be as high as 50 to 70%. The actual incidence in the country is somewhere around 1%, remembering that episodic migraine and migraine disease in the country is estimated to be somewhere now over 40 million individuals. And so we're talking about a disease that's very common, tremendous disability, and a disease that affects most families around the country will know somebody who has migraine. It's a very genetic disorder, very familial. But getting back to medication overuse, the question that patients come in is, oftentimes they'll come in with the question that, gee, I have headaches 4 days a week or 5 days a week, and how many days can I take my rescue medication? And so we'll talk a bit about both, and I know some of the previous talks have been about rescue, and also about what to do for prevention or prophylaxis to prevent the headaches. So if these individuals, oftentimes, maybe they've just been taking ibuprofen, Excedrin, or something more potent like Furanol with butabitol, which is one of the, if not the most one of the easiest to generate medication overuse is butabitol, which is in products like Furanol and some of these products. But butabitol use, if someone's taking even as little as 4 doses a month, can trigger medication overuse. For other drugs, it depends largely on the medication. Medications like Tylenol may take 8 to 10 doses a month. The triptans, around 10 doses a month. The non-steroidal anti-inflammatories, which are ibuprofen and naproxen sodium, Aleve, and some of these, you may be able to take up to 8 or 10 doses a month, but as one patient came in recently and said to me, he said, well, I understand, I've read about rebound headaches, medication overuse headaches. So he says, what I do is I take Excedrin on Monday and Tuesday. I take ibuprofen on Wednesday and Thursday, and I take Tylenol on Friday and Saturday. And I try not to take anything on Sunday, but sometimes I'll take a multitude of those drugs. And what you have to understand, it's cumulative. So the magic term, if you hear nothing else about this disorder, if we can stay at medicating for rescue at 2 days a week, typically you won't get medication overuse headache unless you're using butalbital for both of those. Or narcotics. Narcotics, again, as little as 4 to 6 doses a month can trigger medication overuse. But it's cumulative doses. And so that's a real key. So first of all, you want to realize that because a large number of people have medication overuse, and it's not because they want to be abusive or anything else, they're just trying to get relief. They're trying to function. And maybe their rescue medications don't take their headache totally away, but hopefully they reduce the intensity so they can go to school, go to work, live a life. And so it's a very complicated problem, because when we talk about treatment, which we're going to do now, is what do you do when you're in that spot? Because a lot of migraine patients have been in that situation where they're taking medication every day. And even children. I do a lot of pediatric and adolescent work. I saw a new child just recently and his pediatrician didn't know any better, but he was taking either ibuprofen or Excedrin every day for the last 6 months, and wondered why. He started out with 1 headache day a week, and the mother was trying to figure out why it had gone from 1 day a week to 2 days a week to now he had not had a headache-free day in almost 6 months and wasn't able to go to school. So medication overuse is a subgroup of secondary headaches in the family of chronic daily headache. And so the treatment is very similar. Now, the big question, and we're going to have one of the researchers come a little later talking about a study that they're doing at the university right now on medication overuse. But one of the big questions is, what do you do when you have somebody who's taking medications 30 days a month? And the answer is, number one, you have to get rid of the primary offending drug. And so one hard rule is, whatever you're going to use for rescue, make it not something that they're taking right now every day. And number two, you can either do cold turkey, where they literally, if it's not something that they're going to have major withdrawal other than increasing headache, major withdrawal, and that would be something like butalbital or opioids, narcotics, which you have to taper if they're taking very many doses. So you can cold turkey an individual, and if you do, you can plan on the fact, and you tell them that if you're on these medications and you cold turkey, their headaches are going to obviously get worse for anywhere from 5 to 7 days most commonly, but occasionally even for 2 or 3 weeks. And so you're going to have to help them deal with that. The other approach is doing a gradual taper, where if they're on 6 doses a day, you start to bring them down to 4 doses a day and 2, and you gradually taper. And it all depends on which medication they're using as their major offending agent, or if they're using multiple offending agents. And then if you decide to do either of these methods, at the same time you want to explain to them about the disease and what's going on and what you're planning on doing. And one of the big things you want to do right then is start them on preventative medications. So that's just like prevention of anyone with frequent migraine. You'll use any number of classes of drugs, the tricyclics like amitriptyline and nortriptyline, the anti-seizure meds like topiramate, Topamax, Depakote, the beta blockers, propranolol, metoprolol, or calcium channel blockers like verapamil. And at the same time, occasionally, if you can get through the insurance company, you can actually use Botox in addition with your tapering effect. But none of the preventatives in medication overuse headache are going to be much use unless you get rid of their acute use of daily or near daily rescue medication. So you've got to do a combination of both. And we all know that if you go to a preventative, they may take anywhere from 1 to 3 months to really kick in. So what are you going to do during those first week, 2 weeks, 3 weeks? And there are a number of approaches for that. You can use some of the long-acting triptans if they haven't been using a triptan, which would be like maybe nartriptan, something like this. And you can even use that for a few days in a row. You can use a steroid burst, which is prednisone or one of the other steroids, where you give them a course of prednisone while they're abruptly withdrawing from their others, because that'll calm things down and get their headaches at a lower level. We can do nerve blocks, we can do IV regimens. So there are a lot of different things that I like to look at it as a bridge. It carries them through that most crucial time when their headache, otherwise if you just said, oh, don't take anything, see you in 3 weeks, nobody's going to do that. So it's a real difficult problem. So you have to give them other options. Questions?
Excuse me. Looks like I got the time wrong.
Any questions about anything we've talked about so far? Okay.
One question. When you say a dose, do you mean one, like say Fiorset?
Uh-huh.
Is that one? Or if you're taking 2 together, does that count as a dose?
That'll count as 1 dose, yeah. And we're really, that's a good question. Yeah, and that's a good point, because when we talk about days of treatment versus doses of treatment, so it's very interesting. You can have someone who develops into medication overuse headache who's taking 1 Excedrin every day, 5 or 6 days a week. And they can transform totally from episodic to medication overuse. And you can have somebody else who's taking 2 Excedrin 2 or even 3 times in a day, 1 or 2 days in a week, and most of the time they will not develop into medication overuse. And I'm not picking on Excedrin, but it's, I think, given what I see, it's probably from what I've read, it's probably the most common over-the-counter rebounding or medication overuse causing drug in America. Opioids are close behind, and butabitol is always the nasty one, but most people are getting away from butabitol. Thank goodness. Nerve blocks are a huge benefit in medication overuse, because does everybody know about nerve blocks? I think it's going to be a topic actually in a couple of weeks or 4 weeks, but or it's going to be handled. But that's where you're doing nerve blocks on greater occipital nerve, trigeminal nerve, all the trigeminal nerve branches as well, and you can put in numbing agents similar to Novocaine, like the dentist uses, but it's usually xylocaine and Marcaine is what I use. And we can actually break that cycle and kind of help reset. And oftentimes you can do nerve blocks. Safety-wise, they're incredibly safe. They're even safe in pregnancy, which is really cool, because it's one of the few things we can use safely in pregnancy in all 3 trimesters. But it's a real nice bridge, because you can do it, if you have to, even every week to 10 days. And I've known a few people who will even do them 2 or 3 days in a row on somebody who's hospitalized, for instance, with chronic migraine. Any other questions?
Are there any side effects to the nerve blocks?
Side effects of nerve blocks, other than the getting over the idea of somebody sticking a needle in your head. That's the first one. But usually that's only an issue with the very first one. Other than that, the major things you'll see is just the discomfort from the block itself, just from the needle stick. But it's very brief. You know, you can do any number of branches in just a few minutes. Other than that, reported things like infection, bruising are all listed, and that's about it. And to tell you the truth, I've done thousands of nerve blocks over the last probably 10 years, and I've never seen an infection. Bruising is incredibly rare. And they're very effective, and they're very effective in children. It's really interesting because there aren't a lot of options in children, and nerve blocks work amazingly well in kids as well. Other questions? Yes?
Me? Botox would not be a nerve block, but it's the same injection pattern, sounds like.
It is and it isn't. They're both in the head, but Botox is injected predominantly into the muscle rather than around the nerve. And so where the nerve blocks are actually injected around the nerve sheaths of the trigeminal branches, where Botox is given into the muscles that the trigeminal nerves actually send branches to. So they're subtle differences, but they're very different in how they work as well. And both starting, you know, again, the key with treatment for medication overuse really involves, number one, withdrawing the offending agents. Number two, getting them on prophylaxis, meaning preventative medications. Three is really getting the patient to buy into it, because if they don't buy into the idea that they may get a little worse and that you're going to take away their lifeline to their relief, it's never going to work. And three, oftentimes cognitive therapy is very, very useful, and all types of relaxation therapies as well. But cognitive therapy, so working with a psychologist and really a multidisciplinary team is really nice if you have one. Any other headache questions? I know it sounds like an easy treatment, but it's one of the most difficult. And we're talking about, you know, they figure of headache patients that over 1 to 2% roughly have medication overuse at least. And when you talk about headache centers, like I said, the incidence is the majority of the patients who come in have some element of medication overuse. And so the goal too is not to cure their underlying primary headache, whether it's migraine with aura, migraine without aura, hemicranium continuum, the list goes on and on. The goal really is that we're not going to cure their migraines, but to get them back to a functional level. Because again, when you get to chronic migraine and chronic daily headache and medication overuse headache, functionality, disability skyrockets. And a vast majority of these individuals aren't able to go to school on a regular basis if they're school age. They're not able to work on a regular basis. They're really very, very debilitated. And they don't have a life. I mean, they don't have a family life or a friend life or social life. So it's really important to identify these individuals and treat them. And all too often you'll see individuals who nobody really asked how many days they were taking. This is kind of a side shoot, but where nobody really asked them how many days they were really taking medications, and they keep giving them one preventative med after another at the same time the person is taking all these rescue meds, and they will come in commonly and tell you, I have tried every preventative out there, and none of them touch me. And basically, you need to get them, you know, talking about everything that they take in. I mean, you can get medication overuse from caffeine, from coffee, or Diet Coke. Oof. But yeah, you know, which is a popular one in this region for some reason. But we see that commonly, and so, you know, caffeine has always been something that's kind of interesting in that some people use caffeine to help with their headache. You know, they'll tell you, gee, if I catch it early and I take, you know, 2 ibuprofen and a Coke, I can get my migraine to go away. And indeed, if you get rare migraines, that may work, and that's wonderful if it does, if you're that lucky person. But the person who pretty soon is drinking 3, 4, 5 Diet Cokes a day, or they're drinking 6 cups of coffee, you know, when you get up above 200 milligrams of caffeine a day, then it oftentimes becomes a rebounding agent, which is why everybody knows that if you are drinking a lot of coffee or a lot of Coke and you stop abruptly, it will trigger a headache for a lot of people. Same way the Excedrin would, same way the Tylenol or any other drug.
Would non-migraine, like say a tension-based headache and muscle spasm type of a headache, be included in the same discussion?
You can certainly take somebody with tension headaches and turn them in and have them be medication overuse at the same time. So one of the things you try to do is sometimes you really don't know what some individuals will get referred to you who literally have had a headache every day for 20 years or more. And they have taken medication every day for 20 years. And when you ask them about when it started, oftentimes they can't remember what their headaches were like when they first developed headache. And oftentimes you can't figure out exactly what you're suspicious of one type of migraine or something else, but you may not know what type of headache they truly have until you break them from the medication overuse, and then they start to have episodic headache, and you say, oh, well, you had, you know, episodic migraine without aura, or you had episodic migraine with aura, or you had one of a number of other myriad of primary headaches, but the dominant headache at that point in their life was actually medication overuse. So you don't find out sometimes for weeks or months.
And then one other question, beta blocker, is that a hypertension
Yes.
medication?
Mm-hmm.
And that's used as a headache prevention?
That brings, yes. And I know that's been talked about a couple different times, but let me just go over that for a second. Of the main classes of preventatives that we currently have in the United States and in the world were all developed for other diseases. And they happen to, by observation, it was noted that they reduced the number of migraines. And so if you look at the current medications of the beta blockers were developed for heart disease, angina, hypertension. If you look at the anti-seizure meds, well, Topamax, Depakote were developed for seizure disorder, and they were noted to also reduce headache. The calcium channel blockers, again, were developed for hypertension. Tricyclics were the very first class of antidepressant in the country, and were used at much higher doses than you need for headache prevention. So that's one of the things that's so exciting, and I'm sure we'll talk about that as over the next few months a lot as it comes up. But the first class of migraine preventative that was developed specifically for migraine is going to be launched this spring or early summer. And that's the monoclonal antibodies against CGRP. And CGRP is calcitonin gene-related peptide, and say that fast 10 times, but which is why everybody shortens it. But it's a neurotransmitter that's released from the neurons in the brain. And migraineurs have many migraineurs have much higher levels of CGRP in their system. And it's released by both the central nervous system neurons as well as the peripheral neurons. And it's very, very exciting because these monoclonal antibodies are very specific. And the way I like to look at it is, if you think about what we have right now, if you look at migraine and you think it's a target on the wall and it's like yay big, and you throw our current preventatives at it, it's kind of like shooting it with a shotgun. If you're lucky, it hits the target, which none of the current preventatives work much better than about 50% reduction is a fairly good response. But they may hit the target, but they also hit a lot of other things, which leads to all the side effects that if any of you have taken many of these drugs, you know that some of them you tolerate and some of them you don't. And so there are lots of side effects with the beta blockers, calcium channel blockers, tricyclics, etc. The anti-seizure meds, I mean, the list goes on and on. But the monoclonal antibodies, the way I envision that, is they're almost like shooting a laser beam at that target. They literally either go directly to CGRP, and in a simplistic form, they bind it, neutralize it, metabolize it, and destroy it. Or they go directly to the receptor on the neuron that releases CGRP and bind to the receptor and block the secretion. So this is a very, very exciting class of drug. The first launch is going to be supposedly in May. The good news for all of us is that there are 4 different companies that are all developing these monoclonal antibodies against CGRP. So hopefully it leads to better competition and bargaining, so the price is not too crazy, but that's really exciting. And in the studies, they're finding in the first studies, these were all in chronic migraineurs. So like the criteria for medication overuse headache, at least 15 headache days a month, 15 to 30 headache days a month. And in some of the in the monoclonal antibody studies, about 15 to 20% of the patients receiving 1 dose of the medication would go to 0 headaches within 1 day to 2 weeks. And they, and of the other 80%, a high percentage of those individuals didn't go to 0, but they dropped to at least 75% reduction in frequency and severity, which, if you're having 25 or 30 days of migraine a month and you drop by 75%, you're dropping, down into a few. And guess what happens when you drop down to 3 or 4 migraines a month with your rescue meds? They work again. So, so that's really what has, I think, the entire international headache community really at a buzz right now, and a lot more interest in research in migraine because of this new class of drugs. Now we just have to wait to see what the insurance companies and how the negotiation between the insurance companies and the pharmaceutical companies go.
Will they allow them to be used in children initially?
Initially, all the studies are 18 to 64, so it's like so many things that will they be used? Hopefully the insurance companies will allow them for some individuals under 18 who have tried everything else and still aren't getting satisfactory results, but that'll be off-label. And the only reason I'm saying hopefully that happens is because we're seeing that we've been doing, Botox has been used in children for quite a long time, even though the first small study just was published on Botox in children, but people are doing it off-label. And insurance companies have actually paid for it for children off-label, just because they didn't have any other options. So that's good. And Botox does work in kids just like it works in adults. Any other questions? Yes?
Question about amitriptyline. If you recently got a notification that it's an antidepressant, if you're taking it for migraines, can it later on then cause symptoms of depression?
And it caused symptoms of depression? It can. It's very rare. In the doses used for migraine prevention, it's usually very subtherapeutic from a depression standpoint. In depression, when the tricyclics first came out, like amitriptyline, the dose was commonly 100, 250, 200, 300 milligrams. I mean, very large doses. For pain relief and for prevention in migraine, the dose typically is much, much lower, so usually you don't get much of an antidepressant effect. In fact, usually you don't get any antidepressant effect, but usually you also don't get depression effect. But it has been reported, and for some people you have to wean them off and go try something else. By the way, on the CGRP drugs, about the only side effects known on the CGRP drugs is a few people after multiple doses became allergic to it, but it was very few. And any drug, there's going to be people with allergies, so that's not surprising.
If this isn't too, were you looking at me?
Yes.
Okay. This isn't too personal. I had really good luck with Botox for probably 10 years. And then after some surgeries, I started taking tramadol around the clock. And tramadol apparently causes headaches, and the Botox stopped being effective, and it's not it doesn't have anything to do with my migraines, but it is causing me rebound, I think.
Yes.
So.
Tramadol, again, is definitely a very strong rebounding agent. And some patients can, again, if you have the migraine brain and the genes for migraine disease, for some people, they can bounce into rebound with very few consecutive days of drug. I've seen people go into full-blown medication overuse headache after taking a narcotic or a synthetic narcotic or some other pain med for, say, after a total knee surgery. And they were taking the medication not for their head, they were taking it for their knee, but your brain doesn't know the difference. So they were still taking it repeatedly, and after even a week, all of a sudden they had a headache every day. And so, and the same thing, it doesn't mean your Botox would never work for you again, but you'd have to first get off the medication overuse, and that's where you'd have to try a bridging and cognitive therapy and some of these modalities. Speaking of which, would you like to talk about your study?
Yeah, absolutely. Guess I'll take the chair. Is that okay, Lauren? Okay, perfect. Hi, my name is Matt Halverson. I'm a clinical research coordinator here at the University of Utah. So I run a lot of clinical trials, mostly with the Movement Disorders Division, but also with the Headache Division here at the university. So I'm just gonna spend a few minutes talking about a study we have going on. It's sponsored by PCORI and Mayo Clinic. And what it is they're looking at two of the standard of care approaches that we take for treating patients with migraines and medication overuse, refractory headaches. So if you chose to enroll in this study, you would just continue on with your standard of care visits with your headache provider here at the university if you are being seen by Dr. Degree, Dr. Ozodogru, whoever you may be seeing. However, you may be randomized, which means randomly put into one group or another. We don't have any say. And these two groups are asking you to either immediately discontinue or transition off of your overuse medication, or to not immediately discontinue. Now that sounds really scary. If you were randomized into the first, so the group where they want you to discontinue immediately, and you had a really bad day and you said, hey, I really need to take that medication in order to function, that's okay, because they have headache diaries. So during the first 3 months of the study, it's a 12-month study, you would be filling out diaries every day if you can. We know that life gets busy. And then month 6 and month 12, you would do the same thing for 30 days, filling in a headache diary. So even though you'd be randomized maybe to that immediate discontinuation arm, it's okay to quote unquote mess up. So that's essentially it. There's no experimental treatment, so this isn't anything new. These are all medications that you would already have been taking. One thing to note that I just forgot to mention is your headache doctor can optimize or change up your preventative therapy. If you're not on a preventative therapy, they can start prescribing you one. Really, anything that they want to change with your medications, they can, if that works for you. They're not really restricted in that regard because it's all standard of care. Does anyone have any questions right off the bat?
Could they do full bridging if they want to do nerve blocks or IVs or steroids? Or are those exclusionary? No, there's no treatment that is exclusionary. The only thing that would be exclusionary is if you have headaches other than migraines, chronic migraines. So if you had tension type headaches of 3 or more episodes, if they have fewer than 3 episodes of tension headaches, you could still be included in the study. And then your preventative treatments just can't have changed in the past 4 weeks prior to randomization. So that just because maybe they changed your preventative 2 weeks prior to that visit date where you're just coming in, we could, hold off on 2 weeks for enrolling you if you were interested in being part of the trial. So it's actually a really flexible trial, being that it's mostly observational. So there's not a lot of exclusionary criteria. As well, if you have a history of head injury and it's been determined that you have post-concussive headache or a headache due to your head injury, that is exclusionary as well. So it's really just chronic migraine.
Review again what exactly the study is studying.
So they're looking at 2 different approaches to treating patients who have these refractory headaches from overusing certain medications, or usually the acute medications, your rescue meds, essentially. So they're comparing if it works, how well it works to ask the patients to discontinue immediately, so the next day stop taking that med, quit cold turkey, compared to not asking you to discontinue immediately, but kind of taking it at your pace with your doctor. And again, it's still flexible. Even though we'd ask you to do your best to stay off that medication, if you were randomized to the immediate discontinuation, it's okay to, as they put it, quote unquote, fall off the wagon. As long as you just document it in your headache diary, just keep trying your best.
So you need to have been diagnosed with overuse?
Yes, yes, which could happen that day. You know, you might have a clinic visit, let's say with your headache provider here, and they said, you know, I think it's pretty clear you have a diagnosis of headache due to medication overuse. Would you mind, would you want to talk to our study coordinator? And then if you said yes, then I would come and talk to you about the study. And if you decided you wanted to enroll, I could consent you there. We could even just do the whole enrollment. It's not very burdensome in the regard of patient visits. It's just really whatever your schedule is with your doctor. There are 2 required visits, which would be the baseline, which could be that clinic visit that day, and then a 12-week follow-up. So about 3 to 4 months is fine, just to see how you're doing. And then whatever else your provider how often they want to see you. All right, thank you so much. And I'll leave some information with Lauren in the back.
So I'm going to open the floor to any other questions about headache disorder, studies, research, where we're going from here, or where we need to go. Yes?
So besides the nerve blocks, what's treatment for people who are pregnant?
That are pregnant?
Yeah.
We can use some IV regimens. The safest drugs when we talk about pregnancy, you know, for acute rescue, acetaminophen is still the go-to Class A category medication if it helps. Metoclopramide, which is Reglan, which is an anti-nausea but also has anti-headache properties, is also very effective in all 3 trimesters, can be given orally, can be given intravenously as well if somebody has a lot of nausea. So it's a very, very useful drug in especially the first trimester, but in any of the second and third trimester we can use it also. Other than that, for rescue, there's not a lot. And in some areas, it's more common when you go to international headache meetings, they're using a lot more triptans like Imitrex in Europe and have been for quite some time. And some of us are certainly in extreme cases using triptans in pregnancy. And it's triptans, sumatriptan's actually been moved recently from a Class D drug to a Class C, which is really very good. They'll never be able to move higher than that because they aren't going to be able to do a placebo-controlled trial in pregnancy, but there's a lot of observational data and there hasn't been seen to be any real significant problems. Yes?
I have a couple of questions.
Mm-hmm.
First of all, when you take your rescue med, is it normal that your headaches will get harder before they calm down? Depends
on which rescue med you're taking and how fast its onset is. The migraine itself, and with the new functional MRIs that they're doing a lot of research with, it's very interesting to watch the spread and the changes. You can, they talk about cortical spreading depression, and I think we've talked about that in some of the earlier meetings, but it really spreads through the brain. And so that march is going on while you're waiting for the drug to get into your system and to treat it. However, indeed, when the first triptan came out, that was sumatriptan, which was Imitrex, and initially it was just injectable, and almost any of you who are around or have tried the injectable sumatriptan may have noticed that your headache intensified greatly, much more than when you took anything else. It intensified greatly before it started to get better. In fact, one of my patients said just the other day, he says, I know when I do the injection of the sumatriptan, it's going to work because I know shortly after I do it, I throw up. And so he knows it's working, but that's the intensification of the migraine. But yes, that's not uncommon.
Okay, because I'm just new. I'm one of your patients, and I started in January, so I'm a guinea pig on trying to figure out the amount I take for my body.
Right.
And I thought it was going to be make me a super person, super girl. So I took my rescue med. I was feeling awful, and then I went grocery shopping. And about 3 aisles in, I called my husband. I'm like, I can't move. Can you come and get me? And so he came and took care of groceries. So the next time I took it, I decided I'd go right to bed. And I fell asleep a couple hours, and I woke up feeling marvelous.
Great.
So,
and you'll probably find a balance that you don't have to either go out and run a marathon or lay down and go to sleep, that you can find that you can do certain things, but other things you probably don't want to do for a little while after you take your dose. Okay? And the other thing, when we talk about rescue meds, there are multiple routes of ingestion. You know, you think about oral medication and you think about, you know, what else is there? And even with the triptans, you can now take a triptan orally, pill. You can take them nasally as an inhaled and absorbed through the blood vessels in the nose. You can take them as an injection. And so there are a lot of meds that have different routes. So if you try one rescue med and you're not getting a good result, sometimes you want to switch and try a different drug, a different class, etc. Or you may simply want to try a different route. And you don't want to give up. You want to keep working, because there was an interesting study not too long ago, and the argument was there's 7 main triptans on the market. Which is best? Wouldn't it be nice? You know, this one's always best for everybody. No, the answer was, it's what's best for you as an individual, and what may be best for you may be totally different. You may not respond at all, but you may respond to another one. So the key is, if you try a triptan, because some people will come in and say, yeah, I tried a triptan and it didn't work. Well, which one? Well, I tried this one. And then what'd you try? No, I just tried that one. And then you know, so that's why I'm back on Excedrin, or I'm back on Furanol. And so the key is, if you try one and you don't get a good response, try another one. And try another one. Yes?
So back to the beta blockers as a preventative.
Mm-hmm.
Are those used, 2 questions about them, are those used for more of a combination type of headache, where you have maybe at times, or I have at times perhaps a migraine kind of a headache, and other times where it seems very much more of a tension?
Well,
headache?
The beta blockers, remember, are preventative, so you're going to be taking those every day.
And are they effective for non-migraine but chronic kind of headache?
No good data on tension headaches, and no data that says they work very well for tension headaches, even though they do have a certain calming effect in the beta blockers. You know, they'll decrease tremor. Some people who have presentation anxiety, like speakers and things, will take a beta blocker because that's an off-label use, of course.
And then also, are beta blockers kidney protective?
ACE inhibitors? Not like ACE inhibitors or ARBs, but lowering blood pressure, if you're trying to protect your kidneys, they do help in that regard.
And again, if anyone else has a question, interrupt me. But just even trying to tease out the type of a headache you're having is complicated.
Yes, and remember, a lot of individuals will have multiple types of headaches and may have multiple presentations with their migraine. I mean, you may have it's very common to have both migraine with aura and migraine without aura. And some people are, 90% are with aura, and other people are, I only get aura a few times a year. And the rest of the time it's without aura. So you can have multiple types, so it's not mutually exclusive. If you say, gee, I have migraine without aura, but you can still have one of these other types of headaches as well, including tension. Any other questions? Yes?
Can you explain how the antidepressants help the migraine pain?
We don't totally know. And we don't totally know the mechanism of a lot of the preventatives out there. So this new class, we actually know, when there are a lot of theories about how a lot of different medications, we all use the term that all these classes of preventatives in some way calm down the trigeminal nucleus, which is where the majority of the migraines are coming from, and that they calm that down some way, make it less hyperreactive to all the triggers that we have. And so, but we don't know exactly the mechanism. Now with the monoclonal antibodies, we think we really do, because we know exactly what they do, we think. We may find down the road that there are other things that they're helping with and why. But right now it appears that's the only thing they do. Other questions? Yes.
I had a friend who went to the Cleveland Clinic and had some nerves cut.
Mm-hmm.
Does having nerves, which would be the same as my having Botox, I believe, just permanent.
Except it's probably not permanent, but that's okay.
Well,
no.
That's what she said,
yeah.
actually.
Right.
Hasn't worked out too well. But is that consistent anymore with this new theory of the CGRP? Or?
No. And there's a huge amount of debate if you go to the International Headache meetings or the American Headache Society meetings on is there a role for even more invasive treatments like migraine surgery. And there's a certain group of plastic surgeons, and it's a very small number of them, who feel strongly that they can cure a lot of patients. And believe me, I have a number of those patients who who have had the surgery and they still have bad migraine disease. I mean, migraine is not a peripheral disease. It is truly a brain disease. And it is an inheritable neurological disorder. It's not just a headache, and I can't stress that enough. And so, you know, I don't doubt that some patients may benefit from having peripheral nerves blocked permanently, even though the nerves will grow new fibers. And a lot of those patients that I've seen, you know, had a period of time where they thought they were doing quite a bit better. Whether that's placebo or not, we don't know, because you're doing a big procedure and you're sure hoping that it's going to work, but we don't know. Maybe it does help, but a lot of those people, as you follow them over a few months or a year or two, they're often right back where they started from.
She's one of those, Doctor.
Yeah, quite a few $1,000s lighter, but they're back where they were.
All right, so this is a totally different theory.
Yes, and it's a minority theory, and I you know, I mean, I'm not trying to say they're, you know, desperate times, desperate measures, but there's no real good data to support it when you look at their data that they present.
Thank you.
Yes?
Anything to prevent exercise-induced migraines, besides like dosing with meds right before you exercise?
Preventative before, you know, using a number of different things have helped. And a number of the preventative classes have helped, as well as some of the acute medications. So yes, you can do things to help prevent those. And one of the biggest things is graded conditioning program. And so the key is, you know, when we talk about lifestyle for migraine and everything, and we talk about, you know, eating on a regular schedule and don't fast, don't skip meals, these things, sleep on a regular schedule. The migraine brain likes consistency. Well, the same thing with exercise. And the key is to start an exercise program and try to do it literally 7 days a week. And start slow. And what you want to do, and people say, well, what's slow enough? Slow enough is that when you do it, you don't get a migraine at the end of it or an hour or two after the exercise. And then every week or 2 or 3 weeks, gradually increase intensity, duration, and you can get people back to really if they're world-class athletes, you can get them back to world-class, you know, going 110%. But you have to go slow. And if they take a long break off, they have to start back and start slow again. Yes?
Yeah, are there any drugs out there that are being used in other countries that look promising that are not being used in the United States?
Oh, there have been a number that have kind of come and gone, but right now the big class from a preventative standpoint internationally all over the world has been this monoclonal antibodies against CGRP. And I don't think we're going to find that CGRP is the only neuroinflammatory or the inflammatory agent in the brain, but it's certainly a dominant one. But those studies are going on throughout the world actually right now.
On that note, just because it's such a national topic right now, medical marijuana and headaches.
Right now there's a lot of studies going on. Most of those are not going on in the state of Utah, but they are going on around the country in different parts of the country. There's also so many different chemicals and forms that they're really trying to purify and figure out what it is that's giving benefit versus giving the high or giving the mellow or whatever it is. So, and I will tell you, there's a lot of people who will come to you who say, yes, by the way, you know, I did try, you know, marijuana, I did try this form or that form, and you'll find some who say, you know, I got some benefit for a while, but you'll see just as many people who come back and say, you know, I tried it and it doesn't work. And if you look at some of the you know, the Migraine Again and some of these sites online that where people talk and chat, you'll hear that same thing. There's a huge wide swing between who felt like it gave them some benefit. I think there may be some component in it that does give us some benefit. I don't know. Yeah, it's too early to tell right now. Yes?
A question about yoga.
Yes.
I find when I do yoga, it makes me feel really good at the time, but then like the next day, my headaches are worse. Is that normal, or is that something I need to ease into, maybe? Like?
Yeah, it depends on what kind of yoga you're doing. If you're doing like the yoga if we do here, yeah, then it may still be, you may be pushing a little bit, still a little bit too hard, and you may want to just back off just a little bit, and then try to do it again. Consistency is the key, just like any other exercise. And if you can start doing some every day for maybe even just 15 minutes, to do it as close to every day as you can, and then gradually build into it, then you won't have that kind of flare the next day. Okay. Thank you very much.
Thank you.